Hormones are so incredibly powerful. They're invisible. We can't see them. We can't touch them, but they just control every facet of our lives.
Have you ever felt like something in your body is just off? Your energy's shifted, your weight feels harder to manage, your sleep is different, your mood is unpredictable, and you're left wondering, is this just life? Is this just aging? Or is this something deeper going on? Well, today our conversation is all about getting answers, because so often the missing piece is something we don't talk about enough.
You either have too many hormones or too few hormones. You can take them away, you can block them, or you can raise them. I went into endocrinology because everything's fixable. Don't be scared. You can take a deep breath. We can fix what you have.
Welcome back to Inside the Wellspace. I'm your host, Kathy O'Brien. Joining me today is one of the leading experts in that world, Dr. Caroline Messer. Dr. Messer is a double board certified clinical endocrinologist practicing on the Upper East Side of Manhattan. She's the co-founder of Fifth Avenue Endocrinology and the founder of Well by Messer, a multi-specialty group that's grown to several offices across New York and Connecticut, with Florida coming soon. And you've likely seen her as a trusted medical voice on Fox, NBC, CBS, and beyond. She trained at Mount Sinai, which we love, graduated from Yale, has been named a Castle Connolly top doctor year after year, and has received the Exceptional Women in Medicine Award since 2019.
There is a shortage of endocrinologists, but it truly should not be a luxury.
What I love most about Dr. Messer is how human she is. She comes from a deeply empathetic family of physicians, and her path into endocrinology wasn't a straight line. Today, we're breaking down what endocrinology actually is, the endocrine glands, the chemical messengers that are hormones, and what happens when they're out of balance. We talk about how endocrinology overlaps with so many other specialties, why so many people come in for things like weight changes, menopause, symptoms, bone density concerns, thyroid, and we get into some of the most asked topics about today, GLP-1s, and the overwhelming amount of misinformation people are navigating today. Whether you've been dealing with symptoms you can't really explain, you're entering a new phase of your life, which we as women do regularly, or you have a health issue on a deeper level, this conversation is for you. Here is our conversation with Dr. Messer.
I have nothing left to say.
There's nothing left to say. I'm like, wow, that
Thank
was
you
deep.
for that beautiful introduction.
You're welcome. Isn't it kind of cool to hear about your own self? And you're like, wow,
she sounds great. I wish I could do that.
I want to see her. Well, okay, so we met because when I got diagnosed with cancer, breast cancer, literally like 3 days before I was diagnosed with osteoporosis, because I had just gotten my first bone density test. And one of our favorite people, Dr. Holly Anderson, said, you need to go see Caroline Messer. I was like, immediately. And so you worked with me, and I didn't really understand the whole umbrella of endocrinology at all. So I know it's big and there's a lot for us to talk about. Can we just start, why don't you start by talking to us about you? Tell us about you, how you got into it. Tell us everything.
Well, medicine for me was never even a question. It was a foregone conclusion, not because of any pressure whatsoever from my family. I never had any academic pressure from anyone, but because I was surrounded by it, and because I respected my grandparents and my father and my aunts and my uncle. Everybody's a doctor. Wow. So very unusual, of course, that I had a grandmother who was a doctor.
Yeah.
She was training in Germany right before the Holocaust. She was top of her class, phenomenal. Actually met my grandfather on a train on their way to medical school for the first day, fell madly in love. They had just finished medical school in the late 1930s.
Yeah.
And at the time, I mean, this I think is a little bit of family folklore, but sort of true. So she came from a very wealthy family. Nobody in her family was a doctor. They were all industrialists. And because of that, in the mid-1930s, they were friends. They were pretty high up. They were friends with some of the Nazis. And it was actually somebody in the Nazi party who told them they had to leave.
Thank God for that.
It's like kind of embarrassing. I mean, before Hitler was what Hitler was, there are
but
photos
they saw it
of
coming.
My grandfather doing like a Hail Hitler, who was Jewish, because nobody knew what that meant, right? And, they were wealthy and they were involved in the government. Anyway, so they did leave. They did bribe a janitor to get out their diplomas. They settled in New York.
Oh, to get their diplomas from the medical school.
From a safe, from somewhere. They had to get their diplomas. They arrived in New York, and somehow at that time you didn't have to repeat a residency. They opened up a practice in their townhouse in Brooklyn.
Wow.
In Crown Heights, where they practiced forever.
Okay. That is a great, that's a heartwarming story of thank God, right?
Thank God.
Because then now comes the lineage of your beautiful family.
Yeah.
Right? And all the great work you've done. So that started the family going.
Yes. So two out of their 3 kids became doctors. I became a doctor. I have 4 kids. Hopefully 2 of them say they want to be doctors.
Well, I know one of them wants to be a vet. because I met her. And that's adorable.
We don't really count her because she's only 8. But
That's
she wants to be a vet.
That's great. That's cool. So then, okay, tell us about your how did you evolve? What got you where you are? Because endocrinology is so specific. What was your pathway?
Well, I hadn't heard of endocrinology even when I was applying to med school. You know, it's pretty esoteric.
Yes, it is.
It's less now,
Yeah.
but back then, I mean, there was no weight loss management. There were no FDA-approved medications for weight loss.
Mm-mm.
I mean, it was very limited in terms of how you could treat bones and diabetes and all that. So it's not something that a 22-year-old kid was thinking about. I was sure I loved kids so much. I thought, okay, I want to be a pediatrician.
Right.
I was also like legally blind, so I thought maybe I'll be an ophthalmologist. And when I got to med school, first I realized that I got very squeamish when eyes were bleeding, like squeamish to the point that I was throwing up. I was like, I can't do this.
Nope, check that box.
I was like, that's not going to happen.
Not happening.
And then I thought about pediatrics, and my first rotation on pediatrics was pediatric oncology.
Oh, jeez.
And I tend to get very attached, which is good.
It's good for a
I think,
doctor, of course.
but pediatric oncology was too hard for me. Some
Yeah, I
people,
get
I'm
that.
sure, could handle it. I couldn't. I was like crying in the broom closet.
Aw.
And
I get that
so,
though. You know,
I
that's
really
so
thought about
sad.
like, what do I want long term? And I knew I wanted a specialty where there were answers.
Mhm.
So neurology is fascinating, but you make the diagnosis and then what? Right. So that really bothered me.
Right.
I'm sort of practical. I like to have like diagnose the problem, fix it.
Mhm.
Like in life
Yes.
as well as in medicine. I sort of had the same issue with rheumatology. Like, okay, back then it was before we had more medications. It was like you can give steroids and then you cause diabetes and then you need the endocrinologist.
Ugh.
So the most practical of all the fields was really endocrinology. So you either have too many hormones or too few hormones. You can take them away. You can block them or you can raise them. I was like, this is for me.
Is it that simple?
I mean, no, I'm oversimplifying.
But that's good to actually, it's good to know as like an umbrella. Oh, it really is about my hormones.
Yeah. I do say I went into endocrinology because everything's fixable. Like,
love
don't
that,
be
though.
scared. You can take a deep breath. We can fix what you have.
There's so many nuggets in everything you just said, but one of the things I kind of love is that you know yourself well enough.
Yeah.
At a very young age, you knew yourself well enough, which a lot of women don't. I'm going to generalize just because we're so busy outwardly focused versus inwardly focused. I'm, again, generalizing, but that's kind of beautiful. And that's a really important message, I think, for people to hear is, you know, you really got to think about what's going to work for me.
Yeah. The other thing I knew from a young age was that I wanted continuity.
Yeah.
I love the idea of a family doctor.
Yes.
And that's what my grandparents were, like getting to know the whole community.
Yeah.
I did not want to be an ER physician, urgent care physician. I wanted to grow old with my patients, which I am growing old. I'm growing old with my patients for sure. You know, I've been practicing, 16 years, and I still have patients from that first week in practice.
You do?
I do.
Was it scary opening your own office? I think about that.
When I started, I wasn't in my own office. So I started in Westchester.
Oh, you did? Where?
Mount Kisco Medical Group, which then turned into Caremount and then turned into Optum.
Okay.
But a lot of those patients have followed me, and I still see them in my city office.
That's my
We've
son
known
went to
each other
school in
forever.
Bedford. That's why I raised my kids
Oh,
in
okay.
Westchester.
Yeah.
So I know Mount Kisco. Yeah. Oh, that's great.
Yeah. So no, it wasn't scary. It was
Okay.
wonderful.
Good.
I couldn't believe people were trusting me. I was like, where's the attending?
I know, right?
Yeah.
How is this? It's funny because I'm getting my social work license now because I want to be practicing with women, even though I've helped women on the side at like the domestic violence hotline. But to actually practice is a completely different thing, you know? And I talked to my therapist about it. I'm like, how do you do it? She was like, you just do it.
Yeah.
You just do it.
Yeah.
And then it becomes okay,
Yeah.
you know, because you know what you're doing, obviously. Well,
Definitely.
obviously.
Although I will say I have polished and repolished my methods so many times over the years. I feel like certainly 16 years later, I think I'm much better than I was in the beginning.
Of course. Well, look what we're going to get to it, but you've evolved your practice into something so fantastic. Okay, so you decided on endocrinology.
Yes.
And you also wanted kids. I remember you saying
Yes.
that. You wanted a family. You wanted children. You have 4 girls, right?
I have one boy.
One boy.
Yeah,
Okay, good.
he's
So you've
16.
got that in the mix. Oh, that's
Yeah.
so good.
Yeah.
So you were able to say, all right, this is what I'm doing. This
Yes.
is my path. So for all of us in the room who really don't understand endocrinology, can you give us, what is endocrinology?
So in its most basic form, it's just the study of hormones.
Okay.
And then here's what I tell my 8-year-old.
Okay.
What is a hormone? I say it's a little messenger that sends signals from one part of the body to another.
Okay.
So it has to be produced in one place in your body.
Your
and then
hormone.
Your hormone.
Yep.
Otherwise, not a hormone. And then travel through the bloodstream and then bind to a receptor. like a place that accepts it
Yep.
in another part of the body.
For a purpose.
For a purpose. So we have other things. There's the paracrine system where you produce hormones in one place, or you produce some substance in one place, and then it acts in that place, in the same place.
Got it.
But for
a
it to be
purpose.
endocrine,
Yes.
it has to actually swim through the bloodstream and go somewhere else.
It needs to move.
It needs to move.
So the whole purpose of the endocrine system is that it's like it's a conduit almost.
It's a conduit.
It's
Perfect.
a conduit. Oh, I love that word.
And there
actually.
are so many. So, in terms of how many actual hormones there are over 50. In terms of hormone-like substances in the body, there are hundreds and hundreds.
Hundreds.
So, when patients come in and say, please check my hormones, I'm like,
know.
I don't know. Let's talk, and then I'll figure out what hormones. Like,
what hormones? Exactly.
That's the art of medicine, right? Figuring out which ones. We can't just check them all.
Right. Yeah, I love that we were talking about something and you said that you always, when you get information from somebody else, you always want to look where it came from.
Yes.
Because who was giving you that data? Because you're reading it and it's an interpretation, right?
I always go back to the raw data. I think a lot about history class.
Yeah.
When I first learned, go back to the primary sources. And I was like, why? It's so much easier to read the synopsis. I remember a history teacher in 7th grade saying to me, because somebody can misinterpret it, you need to go back to the primary source. You need to read the Rosetta Stone. And it's like that with medicine. If you trust other people, you can really get into trouble.
You can get into trouble.
I'm not saying I'm a conspiracy theorist or don't believe people, but I always track down labs, even if it's from 10 years ago, because your polycystic ovary, PCOS, diagnosis may not be correct. I may not agree.
See, and that is so exactly right. Look at what happened with HRT in the study and all the, years and years that we were without it. And here we are now oh no, you have to go back to the study and actually look at it from a different lens.
Right.
So wait, you were asking about what the Wellspace is and what inside the Wellspace is before. It's exactly that. It's like the lens through which this particular expert is talking to us about this particular thing that women need to know about. So, and it's trusted and it's data driven and it's real. It's no BS and because there's so much misinformation out there about everything, obviously, but we're talking about our bodies and our health and what the heck do I do? Just thinking about hormones is a lot. You said some really interesting things when we were talking about it. So you said it includes the glands. The endocrine system includes our glands, right?
Yes.
Thyroid, pancreas, pituitary.
Adrenal. And more.
More?
Even the pineal gland.
Is that right?
Yeah.
Do each one of those glands make hormones?
Yes. That's the definition of gland. It produces hormones.
Oh, it is?
Yeah.
See, this is a learning opportunity for I need to know things.
One of the reasons I fell in love with my husband was 25 years ago. We were on a date and he was like, oh, what are you going to specialize in? I was in med school and I said endocrine system. And he said, what hormone does the pineal gland produce? And I was like, I don't know.
I think I need to marry you.
I think I need to marry you because that endocrine is the study of hormones and glands. Yeah.
And you knew the pineal gland.
And so I married him.
Oh my gosh, that's so cute. Did he ask questions like that ongoing?
Oh yeah.
Or had he done his research?
No. This is like a first date.
That's
he had no time to research.
Oh, I love that.
Yeah, he's great. He knows so much medicine now just from listening to me.
Good.
Drone on and on for the past 25 years.
But it's interesting.
Yeah,
it's really interesting stuff. Okay, so let's talk about the regulation of it, because like you said, homeostasis, that's what you want in your body. So what are they regulating and what do we need to be thinking about?
Okay, so broad question.
Yeah.
So we really have to talk about each hormone.
Let's do it.
Okay. So let's talk about thyroid first because everybody's curious about the thyroid. So first of all, the thyroid hormone is the ultimate scapegoat. When anybody's not feeling well, it's your thyroid.
Yeah.
And the tests that the Western doctors are doing are not appropriate. They're missing things.
Yes.
It's actually not true. Okay. It's very easy to monitor thyroid hormone.
Okay.
And the test is very sensitive and specific. So it's easiest when you're trying to understand thyroid hormone to understand what it's doing by talking about what happens when you have too much thyroid hormone and when you have too little.
Okay.
So thyroid hormone sort of regulates metabolism, but when you're overproducing thyroid hormone, and there are many reasons why, which we can get into, or you're taking too much thyroid hormone, you become jittery, very anxious, you get pressured speech, you start to lose weight, you have frequent bowel movements, not necessarily diarrhea, but you're just going more.
Right.
You're sweating all the time, so you can't sleep. All of these things are too much thyroid hormone. So that can be caused by autoimmune conditions like Graves' disease. You can have nodules in your thyroid, which are not cancer, but they're overproducing thyroid hormone.
Wow.
We call them autonomous, so they're not listening to feedback signals from your brain. Everything is usually very tightly regulated, but these nodules are just happily
do what I
spewing
want.
out whatever they
Yeah.
want. There are other causes as well, viruses after delivery, postpartum. But anyway, too much thyroid hormone, you feel that way.
Mm-hmm.
You don't necessarily lose weight, contrary to public opinion, because you can actually – it revs up your hunger.
Oh, really?
So even though your metabolism gets a little bit faster, you also get hungrier.
You're hungry, right.
So usually weight changes a little bit, but not the way that you'd expect because of the increased hunger.
Yeah, because I've heard just random anecdotally that people sometimes take it for weight regulation.
So yes, there's a lot of thyroid hormone abuse.
Yeah.
Because people want to lose weight.
Yeah.
It doesn't work so well.
No,
Yeah.
the GLP-1s are the answer.
many better ways
right.
to lose
now,
weight.
Nowadays, right.
And the problem with excess thyroid hormone, like unchecked excess thyroid hormone, is that it will lead to bone loss and it will lead to irregular heartbeats if you leave it long enough and can occasionally cause cardiac arrest. So it's not something that we recommend.
I feel like I have a friend who needs to come see you.
I had a very sad situation years ago, maybe 10 years ago, where a young woman with a history of eating disorders had Graves' disease, where her body was overproducing thyroid hormone, and she wouldn't let me treat it.
How come? Because she wanted to stay skinny.
Because she wanted to stay skinny. And, I tried and documented, and eventually she left me because I wasn't giving her the answers she wanted to hear.
Yeah.
But, unchecked for years, it can really be problematic.
Oh.
So I've lost track of her, but that occasionally happens.
Of course.
Too little thyroid hormone, which is much more common.
Yes. My daughter has that.
Right. So
Although
the most
now I
common
want her to
reason
come see
is
you.
Hashimoto's, which
Yeah.
is autoimmune thyroid disease. In other countries where there are iodine deficiencies, it can be because of lack of iodine. Here in the United States, it is not because all the salt is iodized. And so we never really see that. There's some other causes, surgeries, radioactive iodine, et cetera. But when you have too little thyroid hormone, then you typically gain weight. But it's not like you'd think. You're not gaining 50 pounds. You're gaining like 5 pounds, and most of it's water weight and pretty reversible with treatment.
Good.
Even severe hypothyroidism, meaning too little thyroid hormone, we don't see a lot of weight gain.
Good.
But we do see some constipation, some fatigue, some brittle hair, some brittle nails, those kind of things. The periods get a little bit heavier in women. So that's the thyroid.
Okay.
Then we have, what's next that people ask about? Cortisol. Cortisol's becoming a popular scapegoat. It wasn't in the past.
Yeah, people throw that word around a lot.
Oh my God, people throw it around. They're like, I'm sure my cortisol is high because I'm living under chronic stress. But when endocrinologists are talking about high cortisol, they're really talking about pathologically high cortisol, which would be due to a tumor. Again, not a cancer, because really we very infrequently talk about cancers in endocrinology, but either something in the pituitary, which is this little gland that sits right behind the nose but is actually part of the brain. It sits right under the brain. It's kind of the hormonal control center.
Okay.
And you can start to overproduce a hormone called ACTH, which tells the adrenal glands to overproduce cortisol. So not to get too technical, but renal means kidneys.
Yes.
Adrenal means next to the kidneys. So it's this little gland. It's like a triangular gland that sits right on top of the kidneys, and it produces cortisol along with other hormones. So sometimes the brain, especially in young women, can be sending this signal to overproduce cortisol.
Right.
Or as we get older, it's much more common to have little masses in the adrenal gland that are on their own overproducing cortisol.
Okay, this is totally tangential. So something about estrogen in the kidney, or the kidney producing estrogen, maybe it's the adrenal gland.
Yeah, the
so
kidney
that's
itself.
probably,
Yeah.
because it's the cortisol. Does it have something to do with that?
Yes. So in the situation where you have a tumor that's overproducing cortisol, there's going to be sort of like a backflow of hormones, shunting production of hormones to testosterone, which then gets aromatized to estrogen. So in that situation, you will have high estradiol estrogen.
Got it. It is so fascinating to me, all of this, and how it links together.
Yeah.
Right?
Well, it's also job security. Because nobody understands it. So it's like, I will always have a job.
Wait, I feel that way about social work, frankly. People are always going to need help.
But so even the smartest doctors are like, oh my God, I can't remember all the pathways. I'm like,
I'm right there.
I know them.
I've got it. Come see me. Come see me in my 5 or 6 offices around now in Florida. Wait, I love that. Okay, keep going.
Okay.
Keep going.
So too much cortisol.
Yep.
But not like the amount of cortisol you'd have from stress. Too much cortisol from Cushing's, which is either, like we said, a little mass in the brain. Sometimes you can't even see it. Yeah. Like the masses that are overproducing this hormone ACTH are often like infinitesimally small, can barely pick them up on MRI, if at all.
Right.
Or from the adrenal itself. So too much cortisol, you'll have weight gain.
How do you find that then, if it's there?
By measuring the ACTH, by repeatedly measuring the cortisol by many different modalities.
Okay.
By seeing is the blood pressure rising? Are the blood sugars rising?
Right.
And then actually we can get a little bit more complicated. We can do what are called sinus sampling. Like we can put in IVs and measure it in the brain. And then eventually we just do surgery, which is through the nose, right? It's called transsphenoidal. We don't have to cut open the brain.
Okay, thank God. Good.
So I don't want to minimize what the neurosurgeons are doing,
Yeah.
but thank goodness it's not a massive surgery.
Thank goodness.
This is the way a brilliant neurosurgeon once described it to me. He was like, I go in with a tiny, tiny little spoon, I scoop out a little bit of pudding, and I take the spoon out. I'm like, I know that it's much more complicated than that, but thank you for dumbing it down.
Because I understand now what's happening to my
I'm
brain.
a little less nervous about sending my patients for this surgery.
Right.
Yeah.
That's good.
Yeah.
That's great. Okay.
So apparently the texture is a little different from the rest of the pituitary. So you like go in with a spoon, you
find the pudding.
part that's a little pudding, like
mushy
pudding
part. You're like,
mushy, and you're like, oh,
let's go.
Take this out and retest.
God.
Yeah, and stain it, of course, to see if it's actually producing ACTH.
Okay.
So too much cortisol, you're anxious, you're gaining weight, your sugars are rising, your blood pressure is rising, your periods are becoming abnormal, your male hormone levels are rising. Too little cortisol, which we didn't even get into why that would happen, but I definitely see it. So that's adrenal insufficiency like JFK had.
Oh, I didn't know about that.
Oh, yeah. So President JFK had it. That bronze appearance that he had.
Yeah, he did.
That was because he had an adrenal issue where he wasn't producing cortisol.
Oh, wow. Geez, he had a lot of stuff going on.
It raises up a few hormones in the pituitary, which then cause your skin to be bronzed.
Wow.
But you can pass out, like spontaneously lose consciousness. You have low sodium levels. You lose a lot of weight. I mean, so they each are so like overwhelmingly, I guess, catastrophic when you have too much or too little. And yet people don't even know about these hormones. There's so many more.
What do you see the most in women where she might come in and say to you, I just don't feel right. Like something doesn't feel right. I'm off. I'm bloated. I'm tired. I'm this. I'm that. I don't know.
I mean, it's not always endocrine. A lot of times it's stress, of course, right? Like I'm tired because I'm juggling jobs and children and I'm not sleeping and all of that. A lot of times, like the bloating, they're coming in for Hashimoto's and I figure out that they have celiac or something else.
Right.
Although the leading cause of bloating is really constipation.
Okay.
So, I'm treating a lot of constipation, which actually has nothing to do with endocrine, but I'm so happy to do it because I come from a family of gastros.
Oh,
and I like to pretend I'm a gastroenterologist, even though I'm not.
But you know enough. You know enough.
I don't know. I don't want to have too much hubris, but I did have a drug rep from like a GI company saying like, so funny that there's a gastro here that I didn't know about in my territory. Because I was prescribing so many medications.
Wait, that's hysterical.
Like prescription strength medications for constipation.
Because you know.
I mean, I try.
But that to me also speaks to the headspace of endocrinology. Because something in that it's like it is all encompassing. Like you really do need to know about every facet of the body. You just do.
So in my naivete, in my youth, I used to think like, why did we have to do 3 years of internal medicine and become board certified before we could do our specialty?
Yeah.
But the longer I practice, the more I understand.
How great is that?
It's wonderful.
I think that's so cool. I used to think when I was a kid that you go to your GP and they would know everything. Yeah. I didn't really get it until I got older. But you said something cool like you share the heart with cardiologists. You share the ovaries and the reproductive system with OBGYNs and gynos.
Yeah, we do a lot of sharing. So for the heart, I mean, it's more when the cholesterol is high. We like to think we're lipidologists, which means like we specialize in cholesterol, and so do they, and they're probably better than we are. But anyway, we like to think that we're experts in it.
Good.
We are doing risk stratification, sending patients for imaging and all that when the cholesterol's high.
Yep.
We share a lot with rheumatology, so they do osteoporosis.
Yeah.
So do we.
Yep.
Gastroenterology, oh my goodness, there's so much overlap. But we definitely share the pancreas. So the pancreas, I mean, it's one organ, but it's sort of divided up. I mean, you can't see it, but there's like the exocrine gland, which is producing all the enzymes needed to break down food. And then there's the endocrine gland that's producing insulin, which lowers the blood sugars, glucagon, which is the counter-regulatory hormone that raises it. So we're definitely sharing the pancreas, which is fun. Like,
I feel
like I'm sort of jack of all trades, even though I'm an endocrinologist.
Yeah. I wish I had known about you when I was in my 30s. And I was speaking with a friend. I spent half the day at Mount Sinai yesterday doing my check-ins for all of my shenanigans. And, so I'm like, I get deep with my doctors who I adore. They're so good. And we were talking about you.
Oh, thank you.
And because I said, this is what I'm doing tomorrow, because they always ask about the podcast and how's it going and who's on now and blah, blah, blah. I told them about you and we talked about endocrinology. And I said, I wish I'd known. And one of them said, yeah, I feel like as a 30th birthday present, I'm going to give it to, she said this, I'm going to give it to my niece, a visit to an endocrinologist. And I thought, I should do that for my daughter. So what's the right age for a young woman to have an endocrinologist in your arsenal?
So are we assuming the young woman has no diagnosed medical issues?
Maybe.
Because it really changes, right? If they have a thyroid nodule, they should be followed by me. If they have Hashimoto's, debatably, I should see them. If they have a history of eating disorders, they should really pretty much start early because it can affect the bone.
Right.
It can, right? You know, if there are any irregular periods, they should see me very early on because we make the diagnosis. Is this too much estrogen? Is it too little?
Right.
How should it be treated? What are the issues that come along with it? In somebody who's completely healthy, perfect cholesterol, perfect blood pressure, perfect everything, they probably don't need to see me at 30. Usually I start with women who are completely healthy when they start entering perimenopause.
Which is in like 35 to 40.
Yeah, 40s.
40?
Yeah.
Okay. That's good. No, it's good to know because, for example, I got this diagnosis at, I think I was 58.
Yeah.
I hadn't yet turned 59 because it was like October. My birthday's in December. And anyhow, I found out that I had osteoporosis because my gyno had given me a bone density test, which you're supposed to get according to whatever.
Guidelines. Ridiculous.
65.
It's like,
I mean,
don't get me on my pulpit.
Please get on your pulpit. Talk about it.
That has to change.
I mean, it does.
We're going to have a whole country filled with women with severe bone loss. And by the way, the insurance company recognizes this. They cover it at age 50, and yet the guidelines
they do?
are,
At 50?
So
why don't
they're
we
covering
know?
it as soon as I write perimenopause, I'm getting it covered. And yet the guidelines still say 65. And when we lose the most bone in those early perimenopausal days, those are the days that I can
help
it. Yeah, exactly.
See, that's what I'm saying. Like I was also in the middle of a divorce, so I really wasn't thinking much about it. And I was clearly going through in my 40s perimenopause in my late 40s. I know when I look back, I was like, oh, that's when I was having the night sweats, but I just didn't know. You know, it's too bad. It's a bummer, but here we are now.
Here we are.
And we're
Fixing,
doing the best.
Like I always say, in endocrine, we can fix anything.
And you've been so helpful to me and really a positive. And that's the thing too, when you said you wanted to be like a real doctor, like a Menchie doctor. And I remember coming into you, I've had so many doctors now, this just given my shenanigans over the past couple of years. They're all wonderful. But I remember sitting with you the first time and you called me. You called me and left me messages. I've got one saved because I was like, it made me so happy. And you took it upon yourself to call and connect with my oncologist to make sure that like any kind of bone medication I was getting worked with my anastrozole. Like it was really good. Anyhow, it was great.
Thank you.
Yeah, thank you. So when the hormones are unbalanced, like what happens to us?
So I guess I would ask which hormones.
I don't know.
Just because they're 50. So I mean, let's do menopause.
Let's do
next
menopause
because we haven't really done it.
Yeah.
So a lot of times you ask, okay, what happens when the woman's just not feeling like herself?
Yeah.
Very often it is perimenopause. It's not always. I think it's become again like a catch-all. Like everybody's in perimenopause at age 30 if they're tired and have insomnia, and that's definitely not the case.
Yep.
There's so many reasons for fatigue. There's so many reasons for night sweats. The leading cause. I mean, maybe I can't say the leading cause, but SSRIs, antidepressants, give night sweats.
Oh, they do?
Yeah.
Huh.
So
that's good to know.
And not always right away. Like if you're on Lexapro, 10 milligrams a day, you may be fine for a few years and you start getting night sweats. So that's a cause.
Can it give you hot flashes too?
Yeah.
Really?
Yeah. So they're wonderful, but yes, that can happen.
That's great to know.
Also, vivid dreams, nightmares can cause hot flashes, night sweats. So, we always want to make sure, like, are you super anxious? Are you having bad dreams? Like, maybe that's a cause. Right. Sleep apnea, or you're having trouble breathing, you're waking up a few times during the night. That's a leading cause of, like, soaking your sheets and having to change your pajamas. So we don't always want to say, like, this is 100% perimenopause.
Right.
The difficulty, you would think it would be simple. You just measure the labs. But the labs actually lag very far behind the clinical diagnosis. So the labs will appear normal for a long time until you actually start missing your period for months at a time. The labs just look normal. And sometimes paradoxically, the estrogen, which will eventually become low, it can be higher.
Right.
So that can be like a clue. But it's one of those times where the doctor's really listening to the patient, but you have to look out for pitfalls since there are so many other conditions that can masquerade as perimenopause.
Again, it's just fascinating. The real through line for us to understand as we are learning more about our bodies as women and we are getting more data, which hasn't, been here, is that we change, is that our bodies are changing. It's not, it's not the same when you're 40 that it was when you're 30. Like things, and it can be slowly, but then all of a sudden, right?
Yes. So I have the nicest patient. I mean, this woman would not harm a fly. She said to me, she was in a taxi. This is such a New York story. And she wanted to stop. She was late for work. And the taxi driver wasn't stopping. And she said she snapped at him. And she was like, something's wrong with me. She's like, I never do this. And she came to me. And it just turned out that I was able to measure her hormones. And she was in menopause. And I was like,
love it.
Wow. Like, you knew it. You knew. Like, she's the sweetest thing on earth. I got her on hormone replacement therapy. She's like, you'll be happy to know I'm not snapping at anybody.
That's so good to know, too.
Yeah.
Because you can have sort of the the aberrant moments
like
of
the out of body,
whoa.
like, this is not me.
Yeah.
Yeah.
And it's okay, actually.
And it's okay.
Okay. Oh, let's talk about GLPs.
Yes, I knew that was coming.
Yeah, let's talk about it, because that's
so
a thing.
I'm very bullish, more than most.
Great. I love that.
And I think it's totally reasonable not to be bullish, too. My partner is not, and we basically agree to disagree.
Okay.
Here's how I feel about it. So let's sort of weigh the risks and the benefits.
Right.
So 2026, here's what we know is not a risk. It is not a risk that you're going to get pancreatitis.
Okay.
There have been studies over the past year showing that there's no increased rate of pancreatitis.
And that had originally been a fear.
That was originally a concern.
Okay.
Oh, for anybody who doesn't know what pancreatitis is,
yeah.
It's inflammation of the pancreas.
Okay.
And there are two enzymes, amylase and lipase. They go up super, super high.
Okay.
You're vomiting. You have pain. It's radiating to the back. They used to think you couldn't eat. That's now kind of debatable. You're allowed to eat now, but you have to get on IV fluids.
Okay.
Big deal. So they proved that there was no increased risk. What they do know is that the amylase and lipase do rise in most people on these medications, but it's not a precursor to pancreatitis.
Okay.
So that's no longer a
And
concern.
it's okay that they rise.
Yeah, it's okay that they rise. They go up a little bit and they don't go any higher.
Fine.
And they just stay there.
It's just a
thing. And it's a totally different pathway that leads them to increase. It has nothing to do with, it's like the beginning steps of pancreatitis.
Okay.
So that's one thing. There's no increased risk of pancreatic cancer. We've known that for a while.
Okay.
We used to be sure that there was an increased risk. Well, we knew there was an increased risk of a rare type of thyroid cancer called medullary thyroid cancer in rodents only.
Okay.
Not even all rodents. It was really rats, not even mice. And then we realized that it's just a terrible animal model.
Okay.
Because rats have receptors for GLP-1s on their thyroids and humans don't.
Oh, well then.
And so
there
the
you go.
long-term data has shown no increased risk of medullary thyroid cancer.
Great.
Even so, I'm cautious if somebody has like a personal or family history or any kind of gene mutations that would predispose them to medullary, I still don't do it. But that's more litigious on my part than really thinking that it's an issue.
Okay. Which is fair. I mean that's totally a fair way to look at it.
Right,
yeah.
right. And then there's the blindness, right, that people are talking about. There's this thing called non-arteritic ischemic optic neuropathy, which was one study done at Mass General in an eye clinic where people were elderly and had eye issues. And so there were like a few extra cases of not getting blood flow to the optic nerve. Then in big studies across of Europe, where most of the studies come from, there was no increased risk. So I am not thinking of this when I'm looking at a 25-year-old who's having trouble losing 5 pounds.
Yeah.
Okay. The things that are real.
Yes.
So you might have a little nausea. You might have a little constipation. You may have a little burping because the food is sitting in your stomach. It's getting fermented in a different way.
Okay.
Okay.
Who cares?
Who cares?
Who cares?
Now, on the upside,
people's
lives are governed by their obsession with food and their food noise, and there's misery that comes with it.
It's true.
And I can take that away. Now, do I care if the patient I think already looks beautiful and maybe has 5 pounds to lose and not the typical 60 pounds? I couldn't care less.
Doesn't matter.
Doesn't matter.
No, because it's their choice.
It's their choice.
And it's their body.
If they want to feel happier and not think about food, great. Because we know that, it's probably not applicable to the microdosing or the lowest dose, but we know that at high doses in certain populations, there's a decreased risk of stroke, heart attack, death. Like we're seeing that autoimmune diseases improve.
I know. All these great things.
Addiction gets better.
All of it. Yep.
So
even cancer, right? There's like something about cancer, inflammation.
It's huge. Yeah. So all these weight-related cancers, because when you gain weight, when you become insulin resistant, all of the fat cells, which are called adipocytes, produce hormones that are inflammatory. Or they produce inflammatory markers. They're called like interleukins. They all go up. Yeah. And we can measure them. They go down on the medication.
So good. And a lot of us, when we go through treatment, get big. Like,
right.
Some people don't, but a lot of people do.
Yeah.
And you pack on 15, 20 pounds. It's
Yeah.
not, it doesn't feel good.
So I had an interesting talk with a patient recently.
Mm-hmm.
She didn't have that much weight to lose, but she was on it and she feels better than she's ever felt.
Amazing.
And she said to me, she's like, but I don't want you to think it's just the medication. Like, I'm doing my part. I promise. I'm following healthy diet and I'm exercising. So I'm not cheating. And I was like, and who cares if you were cheating?
Yeah.
Like cheating. Like,
Yeah.
who cares?
Right.
The end justifies the means. I don't even, I think it's great
Yeah.
that you're exercising and like all that's wonderful. And I
Yeah.
try to, get people to do it,
Yeah.
but there shouldn't be any guilt.
Yeah.
Like,
That's a script, though. I think that's a script we have that runs in our brains that I agree with you. Like, we need to figure out how to quiet that.
right. Like,
Just
do you feel
quiet it.
guilty if you're on a statin for your cholesterol? Do you feel guilty if you have to take something for depression, anxiety?
No.
I mean, no.
You're like, thank God.
right.
Thank you.
Like,
Thank you for that pill that I get to take every day. I'm on an
Right.
anastrozole to squelch my estrogen.
Right.
I'm grateful. I
I
literally
love
look
the
at my
pharmaceutical industry. Like,
I do.
there are so many people who are haters, and I'm like, we have all these incredible
Thank God.
medications.
Thank you.
Look at what the world was like in the past. Like,
People, I would have been
like
dead.
Hobbesian,
Are you
like
kidding? No,
brutish
seriously.
little world. Like that is not. We should be so grateful for Advil and Tylenol and all these medications.
All of them. I'm so grateful. And again, I just come back to it over and over again, knowing. You got to know what you've got. Like,
Yeah.
what do you have
Yeah.
inside of you? I think I'm so happy about the GLP conversation. Some of my cancer friends, because I did it. I went on it after, and I had wanted to do it for a while, and Holly wouldn't let me. But this was before cancer. Holly was like, no, because it was like
Yeah.
an Ozempic moment, and
Yeah.
she was like, absolutely not. This was a couple of years ago. And then after, when I bulked up, I was like, I can't, I'm not bulky. I'm not a bulky girl. And now I
Yeah.
feel bulky, and
Yeah.
I can't have it. She was like, do it. But what's great, after I did that, then I heard all about this, like help for anti-inflammation with cancer people, and some of my friends who are younger are on it now, and that it's inexpensive, right?
It's getting much cheaper.
Yeah.
So the oral Wegovy, the starting dose is $149.
Okay. Monthly. A month.
A month.
Okay. And is that like a daily pill? What is
That's
that?
a daily pill.
Mhm.
It's a little annoying. I'm finding this is totally anecdotal.
Good.
But I'm finding that patients are having like a little bit more nausea
With the
and
pill.
a little, like the gastrointestinal side effects are a little bit worse.
Uh-huh.
But it's certainly cheaper. I think we're just getting started.
Yeah.
So there's a medication called Victoza, which
Okay.
I haven't used for years, but I was using, 15 years ago for polycystic ovary syndrome. It's a daily injectable,
Yeah.
and it's gone off the patent, and so it's like $60 a month. I mean,
No
it's,
way. That's
it's
great.
super, super cheap. Most people don't want to do a daily injection, and the weight loss is inferior to what we have now, like Wegovy and Zepbound. But it's something.
Yeah.
It's something I couldn't have possibly envisioned
No.
that it would be off the patent someday
Right.
and cheaper. And all of these will go off the patent. Like, this is just a starting place.
So
And there's so
great.
many more medications, great orals coming out. There's one called
Amazing.
orforglipron, probably
Okay.
pronouncing it incorrectly, which is coming out
Okay.
sometime, maybe the fourth quarter of this year.
Great.
So there's so much coming down the pipeline.
Great.
They're, triple hormone agonists.
Yep.
There's so much to look forward to.
That makes me so happy. And again, empowering all of our very fabulous young and all of us, all women, to be able to say, you know what? I know that at this age, there's no diet that I could do
Agreed.
that is going to get rid of this 5 to 10 pounds that I need
Right.
to get rid of. And it just isn't.
Because I used to think you developed resistance to the GLP-1s. You actually develop a GLP-1 deficiency when you go into menopause.
Oh,
so
you
this is
do?
all hormonal. That's why I'm like, why any guilt?
No.
Like, just take the stupid.
Take it. It's like a
just take
supplement.
it. It's like
It's a
a supplement.
supplement.
You're missing something. I'm giving it back. You'll be happier. You'll think less about it. You'll have
I
more
love it.
brain space to do all the other wonderful things you want to do with your life.
Don't you want to just take that thought out
Yeah.
of your head?
Yeah.
I do. I do. I think back on, when I felt my best in terms of my body, and it was 10 pounds ago. Literally. And it's a real thing. It's a real thing. So I'm focusing now too on, as we get older, the muscle building,
Yeah.
not so much about what it looks like, but what the makeup of it
Yeah.
all is,
So apropos of that,
Yeah.
you probably know, but they're testing medications that would be given in conjunction with the GLP-1
Like
medication.
what to do what?
Like semarelins to see if it's safe to prevent muscle loss.
Oh, that's great.
But to be fair, we
Yeah.
really do believe the muscle loss is an indirect effect of weight loss, as opposed to
Oh.
a direct effect. Just like the Ozempic faces an indirect effect of subcutaneous fat loss from weight loss.
Yeah.
There's so many things like this where it's indirect, but it's blamed.
But I get the fat loss thing. Like I get the, because that's fat, but the muscle.
Yeah.
I don't know. I don't get that. Like, why would it affect the muscle?
Well, any kind of weight loss affects muscle.
Yeah, I guess
every single time you lose. I mean, we have studies looking at bariatric surgeries and you lose a comparable amount of muscle.
Oh, really?
And just to put this out there,
a
lot of the muscle that you're losing may be sick muscle. Like what I mean by sick is if you're insulin resistant, that muscle is insulin resistant. And when they are doing studies in patients who have diabetes or prediabetes, you're really losing unhealthy muscle. So it's not always the worst thing to lose some muscle, and you're replacing it with more sensitive, insulin-sensitive muscle.
I love that. That, again, is really it's very reassuring because we, the gals, we hear these headlines.
Yeah, I know.
Yeah,
but everybody has their agenda, right? They want to be on TV.
And we're just going to be on YouTube.
We're just going to be on YouTube.
We're just going to be on Spotify, YouTube, and Apple. So
can I tell you something else that's really interesting?
Please.
So I have patients all the time who are like, I don't want to go on this because there's a boomerang effect when I have to stop it. Let's say I'm going to get pregnant and I've heard it slows down your metabolism. And then, when I stop it, I'm going to gain 40 pounds more than I originally gained. So that's not actually what the science shows at all.
Okay.
So regular weight loss, you have a slowing down of metabolism. With these medications, you're taking unhealthy fat, like white fat it's called, and you're actually changing it to like tan or brown fat, which helps you have better metabolism.
Interesting.
Which literally does not happen from any other type of dieting. Huh. And so I think
God, this is revolutionary. I mean, seriously.
So we see not only do you not slow down your metabolism, when we test metabolism after people have lost all this weight on the GLP-1s, it's actually often slightly better. So even without increased exercise and weight training and all of that. So it's a lot more complicated than, media is making it seem.
I think it's very, very important what you're saying right now for us. For the women who are in the perimenopausal, menopausal, postmenopausal phase of life, which is frankly a huge chunk of us when you say like 37 to 60-ish.
So my good friend, he's a plastic surgeon. I'm going to make him watch this.
Good.
He was totally joking around and saying this kindly, but he sent a patient to me who had been turned down by another doctor who wanted to be on GLP-1s. Okay. And he said to her, go see Messer. She'd give it to somebody with active anorexia. And I was like,
okay, wait a minute.
My God. That's like, he was like, I was joking. But I said, to your point, I actually think it's great for women who have a history of anorexia, have now recovered, but always have that like niggling
in their mind
thought in their mind.
Yes.
Even if they don't have that much weight to lose, it helps them get out of that mindset and just live like a normal, productive life.
I love that too, because isn't part of the anorexia thing about control?
Correct.
It's control.
Yeah.
And who doesn't want control? So, but that's taken it to another extreme. That to me sounds like a logical.
Yeah. It's not recommended.
No.
No. I do it anyway.
No.
I'm tracking it.
Sure.
In my office. Good. I have not seen anybody have a relapse.
Good.
And so quite the opposite. People are starting to, there are a lot of patients who do these sort of like socially sanctioned diets, which I feel are like a form of eating disorders.
Yes,
but,
totally.
Like, oh, I'm totally paleo and this and that, and I don't eat dairy or gluten or this. And, so that they have to eat very little because they have all these rules in place. Yep. And I find that they stop having those rules for themselves.
Good.
They're like, I ate carbs for the first time in 20 years.
Wow.
Just, they're on GLP-1s and yet they're eating 3 meals a day and allowing themselves like, I tasted chocolate after 10 years. And I'm like, hooray, there's nothing better than chocolate, says the endocrinologist. Like, everything in moderation.
Everything.
Like, let's just like
That's really beautiful. And that is mentally healthy too.
Yes.
So you're doing it's a service to these stories that go on in our heads that make us certain ways about this, about the body, right?
And I get asked regularly by my patients, and I don't mind, but they're like, oh, are you on them? And like, the answer is I'm not. And sometimes I feel like almost nervous to say. Like,
how come?
Why do I feel nervous?
Yeah.
Because I feel like people want doctors, like they want a woman because I understand their womanly issues.
Yes.
Or they want somebody who's struggled with food noise to understand. But I don't think that's what you need to be a doctor. I think you need to have an open heart and empathy and knowledge.
Yes.
But like, I'm not going to have experienced Cushing's and acromegaly and PCOS and like I'm not going to
No.
have experienced everything. And
No.
I feel like I'm still able to treat it
Yep.
properly,
Yep.
having not experienced it myself.
Yes. And frankly, most doctors too, my cardiologist doesn't have heart disease.
Right.
My
Right.
gynecologist didn't, has not had ovarian
Yeah.
cancer or ovary removal,
Right.
whatever. But they do have a sensitivity and a specialty, which is respect, you respect that.
Right.
Yeah. Okay, wait. So tell us about your offices and your
Okay.
your burgeoning empire. Wait, you've got 3 different companies.
That's definitely an overstatement, but
No, it's not. Go. Tell us about it. It's so exciting.
okay. So I have this multi-specialty group. It's
Yep.
called Well by Messer. So right now in Manhattan, we have 2 offices, lots of doctors, plastic surgeons, psychologists, internists, GYNs, lots of endocrinologists, bone
Love.
specialists. Richard Bachman, who is like the most famous, I think, endocrinologist in the world, practically just came from HSS and is doing bone disease in the office. And
Really?
He's like the sweetest, most
Wait, that's awesome.
wonderful mensch I've ever met. He's
And
so
he's in
cute.
your Fifth
He's
Avenue
in my
office?
He's actually in my Midtown office.
Midtown. Okay.
We have pediatric endocrinology. I just developed an app for parents.
That's
Yeah.
the new one. No, talk
So-
about that. What is that? What's it called?
So it's called Growth AI.
Okay.
It's possible that I'll change the name, but right now,
For now. Yep.
while I'm beta testing it. So a lot of parents approach me and they say, my child isn't growing properly. The next time I can get in with an endocrinologist is a year. I need to know, because there's a very small window of time where you can actually do something about it. They're
Yep.
approaching puberty maybe,
Yep.
and you need to know, like, do I need to give growth hormone or puberty blockers right now?
Right.
And so you can either just like pull strings or beg, camp out outside the pediatric endocrinologist's office,
Yep.
or you can try to get an answer in advance. So what this app does is you give your growth curve, you give a few labs, so you have to have labs in advance. You give your bone age and then the parental heights.
And bone age is just your age.
No, bone age is an x-ray.
Oh, gotcha.
And if you don't
Okay.
have any of this, we'll order it for you.
Got it. Okay.
And then we use AI to basically process all of this
Yep.
and tell you the chance that your kid actually does have either growth hormone deficiency or some sort of issue that needs to be addressed.
And the
And
AI
then-
capabilities are sound.
Very sound.
Okay.
We use thousands of case reports, cases,
Yep.
plug them in,
Yep.
and then compared it to the endocrinologist's conclusion.
Amazing.
And so then obviously there are all sorts of legal disclaimers.
Yep.
But if we think that the kid does need growth hormone, then they'll be referred over to a pediatric endocrinologist.
Amazing.
Yeah. So I think it's working out so well that now I want to do this for other things. Like,
Yes.
here's your bone density.
Yes.
Here are your labs. Here's your age. Did your mom fracture? Okay.
Yes.
Do you need somebody stat? And what do we think the treatment might look like? So,
Love.
there's so many ways that we can do this. It's not that it's the answer, but it at least helps you know
It's empowering.
how desperate it is to get you in the door. We can do it with menopause. Are you in menopause or not?
Yes.
Right? Are you just tired, or is this something that's really going on?
Is it a real thing? And what should be
Yeah.
tested? And who should I see?
And we can use like the trackers that people are using and hopefully integrate that data to try to figure this out.
That to
so-
me is unbelievable, because who doesn't want to do it from their phone and
Right.
basically,
Yeah.
again, with the control. I
Mm-hmm.
need to know more about my body. I can do it this way, and then figure out what my next step is.
Right.
I think it's fantastic.
So I find that very exciting.
Yep.
Right. So then there's the Well by Messer. So I'm opening up. I have a Greenwich office. I'm opening
Greenwich,
up
Connecticut.
Connecticut. Sorry.
That's right.
Opening up in Great Neck in 2 weeks.
Amazing.
And that's like a big production with plastic surgeons and like a million doctors.
Wait, what's going on in Greenwich? What did you? What?
What's there?
Yeah.
So Greenwich, we have also menopausal GYNs. I have a few GYNs there.
Okay.
I just brought in like a lipidologist, like a preventative care
Okay.
specialist. She's did a fellowship in cardiology, preventative care kind
Amazing.
of things. An internist,
Amazing.
but lots of endocrinologists.
That's great.
And then so then we have Great Neck, and then I'm in the process of opening Miami.
I'm so excited.
But it's always
about
the same
that.
sort of trifecta. There's
Yeah.
always an internist, there's
Yep.
always a GYN
Yep.
and an endocrinologist, and then a
Amazing.
smattering of other subspecialties.
Fantastic.
And I just basically, I just take the best doctors. These
Yeah.
are doctors I've trained with, I can vet,
God,
I've been friends with, I've worked with for years and years and years. So,
great.
nobody's getting to me through Indeed. Or,
No.
Yeah.
Yeah, you know these people.
I know these people inside and out. Not only that they're fabulous doctors with great pedigrees, but they have wonderful personalities in that they're kind, but they also call people back. Like, I'm like, you
There
must
you
call
go.
people back same day.
I
End of
literally-
business day, everybody needs to be called back.
I'm going to just go back to you leaving me these messages. I literally texted Holly. I was like, Dr. Messer is calling me and leaving me messages. Like, this is the best
She's my
recommendation
stalker.
you've ever given me. No. Anyhow, so keep going.
And then I'm just starting to work on a project in West Palm Beach.
Yep.
but it's going to be a women's center because they already have like a huge atria. They have a lot going on there, but there's no women's center.
Meaning what? What is it going to look like?
Well, it's going to have mammograms there,
Okay.
MRIs. It's going to have some of the best breast radiologists in the country.
Great.
We're going to do osteoporosis, have
Love it.
DEXAs, but it's going to be like, infancy through old age.
Love.
Treating everything.
Oh, God, it's so good.
Yeah.
It's so good. What's your ETA for that?
So that one's a little bit longer.
Okay.
That's a much bigger project. So far, I've self-funded everything.
Yeah.
That one is like a $40 million project with investors.
Okay.
But Miami is just waiting on the permits. So hopefully in 6 months or so, it'll open.
Great. That's awesome. We should do something. There's a great studio down there. I did a live Inside the Wellspace chat about nutrition with a which
well,
was
as soon as I
amazing.
open, I'd love to do
Let's
one there.
do it.
Yeah.
We'll do it. It's a great little studio. We can invite a bunch of people and we'll talk
Sounds
about
great.
it. With everything we've talked about now, what would be the 3 things you'd want to leave her with?
A woman with.
Yes, as we're kind of winding down our conversation.
There is a shortage of endocrinologists, but it truly should not be a luxury. Like you can only go to an endocrinologist if, you're super wealthy and have lots of extra time. It really is a necessity at a certain age.
Yep.
You either have been thin your whole life and you're probably going to have osteoporosis, or you've been heavy in your whole life and you're probably going to have some metabolic issues. Almost everybody needs an endocrinologist.
Yeah.
So remember us.
Thank God I got you.
Yeah, so that's one thing.
Yep.
Hormones are so incredibly powerful. Like they're invisible. We can't see them. We can't touch them, but they just control every facet of our lives. And I guess the third thing I would say is you shouldn't be judged. Like you shouldn't be judged by your family for these medical decisions that you're making with your doctor, if they're sound medical decisions, that science is not the enemy. We should still be practicing evidence-based medicine. There are just so many quacky doctors, but also influencers out there. We might as well live 1,000 years ago if that's what we're going to be following. There is a reason that we do randomized controlled trials and we don't just practice based on anecdotal evidence. There is a reason we take those randomized controlled trials and we look at them en masse. It's called a meta-analysis. Like these are important things. You need people to guide you who actually believe in science. But once you're following those guidelines, don't let people judge you.
I love that. That's very empowering. I can't thank you enough for being here and spending your time and sharing all your knowledge with us.
It's been such a pleasure.
And
You're a great hostess.
Oh, thank you very much. Thank you very much. Well, we'll do it again.
Sounds great.
Yeah.
Next time in Miami.
Love it. We're there.
Okay.
Okay.
Bye.
Thank you so much for listening to this episode of Inside the Wellspace. Subscribe now on Apple Podcasts, Spotify, YouTube, or wherever you listen to your podcasts.